Welcome to the top 10, or I should say top 9 mistakes with infection control and compliance. And what I'd like to do tonight is to go over some of the things that we see at Compliance Training Partners, where we deal with literally thousands of clients across the United States who can run into OSHA compliance problems. We deal with many inspections. We have seen in 2021, I guess, some consistency in things that can happen. And what I'd like to do is see if I can't prevent some problems for your practice. So let's start off, first of all, with what are some of the things that we see, again, in inspections all over the country. We've been involved at one time or another in inspections in almost all 50 states, in protectorates of the US like Puerto Rico, US Virgin Islands. And they're all the same. And one of the top violations, one of the top things that you'll see is not having a written program. So make sure that you have a written program. First thing an inspector is going to look for. And it's so easy to have one. It'll keep you out of trouble. And of course, one of the main things in a written program is a written hazard communication plan. And that's a program that's going to describe how your hazard communication program works. What about access to data sheets and labeling and personal protective equipment? How do you train employees? Now, one of the things that you want to know is this hazard communication standard is also known as the Employee Right to Know Law. So basically, it means employees have a right to know what they're working with, how to protect themselves, what sort of safety measures are available. Some of the things that you want to make sure that you're doing in your office. You want to make sure that you are creating a hazardous chemical inventory. You want to make sure that you have safety data sheets for every single hazardous product you have in your office. You also want to make sure that your containers are labeled. If you have unlabeled containers, people can't tell what's in there. They've got to be labeled. You need to have a training program, and not only to do annually for everybody, but for all new employees. It's part of the onboarding process. And of course, developing this written hazard communication plan. And one thing that we find is you can't get into compliance ever unless you assign somebody to do it. And as doctors, we mean well, we want to do it, we never get around to it. Assign a trusted clinical person to do this, to have responsibility. And this is one of the first questions I'd like to ask the people we're talking about here, and we've got a pretty big crowd. How many of you do have somebody in charge of OSHA and infection control in your office? It looks like about 80% of you do, and that's extremely important. That's the only way that I ever really see compliance achieved. Another question I'd like to ask is how many of you do have a written hazard communication plan? That doesn't mean just having some safety data sheets, but an actual written plan for all the things mentioned on this slide. Probably about 75% of you. Yeah, about 75%. Good, those are pretty good numbers, actually. So the next thing is, of course, having a chemical inventory list. And that's one great thing about working with Schein. It's really easy to go to their website and download the products that you bought, say, in the last year, 18 months from them, to create a chemical inventory. You can then just transfer it onto, say, an Excel spreadsheet and update it as new products come in. In a dental office, you know how it is. We don't get that many new products. We tend to use the same things again and again. So make sure this chemical inventory list is posted, a prominent area on the wall in the office. Also, it's contained in your written hazard communication plan in your OSHA binder. Make sure that labels are on unlabeled containers. The good news, this isn't really a difficult thing because most of the products that you have are labeled. There's only a few that aren't. And what you want to do is have a label like this, which is, of course, something you can get from Henry Schein, to label those products. Unmarked containers have got to be labeled. Again, these are violations, problems, mistakes that we see consistently. We certainly saw them last year. So you say, what is a hazardous chemical? You wonder what it is. Pretty much anything in your office. I always say pretty much any powder, liquid, or paste in your office, things like disinfectants and cleaners and restorative materials, impression materials, even things like plaster, stone, and alginate, all can be considered potentially hazardous products. Remember to make sure that your staff knows how to read these labels. That's another mistake that we see, a common mistake. One of the top mistakes is people not knowing how to read a label. And in a label, the GHS label is going to say what the hazardous chemical is. It's going to say who the manufacturer is. And probably where people sometimes run into trouble is they don't know what this hazard statement means. A hazard statement is going to say either danger or warning. Danger is for the more extreme hazard, things like, say, glutaraldehyde or mercury, where if it says warning, that's a lesser hazard like isopropyl alcohol, for example. So people need to know that. They also need to know how to read these pictograms. There's 9 different pictograms, and this is in an international language that OSHA has adopted called the GHS label, Globally Harmonized System Label, and that's what you're seeing here. So make sure that people know what these mean. I think probably a really good way to do it is to have a wall chart of some type up so that people understand how to read those labels. Now, when it comes to training, this is clearly one of the top mistakes that we see, is that people aren't trained in this area. It reduces liability. Remember, it's got to be done annually. Remember, it's got to be part of that onboarding process. So either buy one or design one, but have a written program, because that is the #1 violation that we run into. The next thing we see that we touched on just briefly is simply not having safety data sheets, or they're poorly organized. People have them, they can't get to them, or people will say, well, what we do is we simply go to the website if we need one in an emergency. That won't fly. You either need to have them downloaded onto a dedicated laptop. It's not battery backup. It's not password protected. It's easy to get to, or simply download them and print them, put them in alphabetical order in a binder. And if someone were to look in your office today, how many of you do have SDS binder that's up to date, ready to go, all the products in there? It's like probably about 60–65% of you. Again, that's something that we see. It's a top mistake, and it's something that you need to assign somebody to do. Whoever's in charge of OSHA in your office should be assigned this task. And again, that's one advantage from working with Henry Schein. If you're buying everything from Henry Schein, it's pretty easy to get these safety data sheets, to download them, to print them, to have them. So again, designate somebody to do this, and make sure that you maintain these for 30 years from the last date a product is used. So you want to have what I call just a dead file, a binder of products you no longer use. Basically keep them forever. And it really is interesting, isn't it? Training records, we only need 3 years. Things like patient records, if we no longer see that patient, we only need to maintain for 7 to 10 years. But SDS documentation, 30 years. And again, they need to be available. Everybody needs to know where they're at. A typical thing that we see is people may have safety data sheets, but OSHA asks in an inspection, where are the safety data sheets? They ask that question to an employee. They don't know where they are, and that can be a violation. So again, not having a written program, not having safety data sheets, that encompasses the first the two major violations that we see. Now here's a simple one, easily remedied: not having an eyewash, or not having an eyewash that's accessible or functioning. And you know, I see this more than you would think. There's actually a requirement that an eyewash be within 55 foot of any chemical hazard? Well, for most of us in our office, that means we only need one eyewash. Okay, so pick a spot that is within 55 feet of any place there could be a hazard in the office, like a laboratory, an operatory, for example. Another key thing, this has to be inspected weekly. And to not do so is one of the top mistakes we see. Many times people will have an eyewash, they haven't activated it in years. You pull the button, nothing comes out but brown sludge, okay? So really, really important to test this. You might say, wow, that's gonna take up a lot of time. No, it isn't. We're talking about a 15, 20 second a week thing. Whoever's in charge of it turns on the water, pulls the button, the caps pop off, you let it run for 10 seconds, done. And check the box. Someone asked here how SDS sheets should be organized by material, alphabetical. I always find it's best to be in alphabetical by the common name, whatever you call it in the office. In an alphabetical order seems to be the best way. Now I'm curious, since we're talking about eyewashes here, how many of you, in fact, do test your eyewash? How many inspect it weekly? How many don't inspect it? How many just don't have one, period? You know, a lot of people don't realize that you need to do it every week. I understand that. But when you think about it, bacteria grows in there, biofilms form, it won't work. Makes sense, it's once a week. And it looks like about 34% of you test it weekly. About 55% don't inspect, don't test, and about 12, 14% of you don't even have an eyewash. So something you can easily remedy. Again, the good news is that most of the things that you see here, where people get into trouble, the top mistakes, are things that aren't tricky. They're not hard to overcome. Just things we forget. We're all busy. We're all running a business. We forget about these things. Now, the next violation that we see among our clients, among people we deal with, is not offering exposed employees the hepatitis B immunization or not having a signed declination. Now, more often than not today, the problem is that there's no records, because most young people today that would work in your office, they've been immunized as part of their childhood vaccination series. Most people have been in dentistry a long time, they've been immunized. The problem comes in when you don't have a proof of immunization in their employee medical record, or if they don't want to get it because they had it years ago, they don't want it again, and you don't have a vaccine certificate that they didn't sign the declination. So please get everybody to sign the declination. What a shame when to get a citation, to get into trouble, when actually the person is immunized, but there's just no record. So one question I'd like to ask, how many of you do offer the hepatitis B immunization to all new employees and make sure that a declination form is signed? Again, the declination form being the key. It's like about 75% of you offer it, about 25% don't. And it could be just that you don't have the declination form, but those are the two key things, either proof of immunization or signed declination form. That will keep you out of trouble. Those are mistakes that you can easily remedy. Again, remember that hepatitis B can cause inflammation of the liver, of course, cirrhosis, liver damage, death. It can survive outside the body for a week. It's 100 times more transmissible than HIV. And that's why immunization is so important. Now, remember that this vaccine is highly effective. You know, we're all so up to date on what's going on with the COVID vaccine now. But look here's a vaccine that has an incredible immunologic memory after 3 doses. It's a great vaccine. No booster dose is presently recommended. Now, this declination Remember that you want to have exact wording on this. This webinar is going to be recorded, so if you maybe you want to take a cell phone picture of the slide, or maybe you want to check back on the recording, but it's very important to have this exact language in your declination. Again, one of those mistakes that I see people make, and that's the goal tonight, is to keep you out of trouble. We got enough things going on in dentistry that make it tricky right now. We don't need to have a problem here. Another thing that I see, a top 9 mistake, not providing baseline TB testing for all employees and all new employees. It's an inexpensive thing. I suggest you Google up occupational medicine clinic in your city. Give them a call, let them know you're a local dental office. You want to have someplace you can send employees to for hepatitis B immunization, for TB baseline testing, because it only needs to be done in a dental office once. One time only, a baseline test. And it's cheap at a occupational medicine clinic, probably about $25, $30. Tell them you also want to have a place that you can send people should there be a needle stick or scalpel blade cut or some occupational injury. Again, all things that I want to do to keep you out of trouble. So tuberculosis, just remember, it's airborne, it's not bloodborne. Much like COVID, it spreads from respiratory droplets, like from coughing or sneezing, laughing or speaking. Remember, there's latent TB infection and TB disease. Those are the 2 types of TB conditions. In latent TB, you're infected, but bacteria aren't actively reproducing. You're not infectious. Where in the disease, these bacteria are actively reproducing. These people are very infectious. They're typically symptomatic. You can't treat them in your office. Where if somebody had latent TB, you could safely treat them in your office. So again, when there is a doubt, a test needs to be done. Much like COVID, you can't treat known or suspected TB patients in your office. Symptoms of TB: fever, fatigue, weight loss, night sweats, chills, chronic cough, coughing up blood and mucus. So a lot of similar symptoms to COVID. I'd like to ask this poll, as you can imagine, when it comes to TB, and don't feel bad if you're not. A lot of people don't realize you have to do it. But the whole goal of tonight is to get better, to learn what the mistakes were, how we can get beyond that. How many of you do provide baseline TB testing to all of your employees? And the response here is typical, about 25% of you. And for the most part, it's just that people don't realize that you have to do that. But mark that down as one of your goals here for the new year, to get this done, to make sure that you do it. Again, inexpensive, easy. And again, the one good thing is we are in what's considered a low risk facility. TB is considered low risk in a dental office, which is why we only need a baseline test. If we were in a medium risk facility, if we worked at Los Angeles General Hospital, likely to see TB patients, then we need to have this test annually. So defer treatment on patients that you suspect to have TB or COVID, right? They can't be treated in your office. Make sure that they remain masked. They are moved away from others. Always make sure that you have a proper cough etiquette, including having signs up describing cough etiquette, having alcohol hand rubs and tissue and no-touch receptacles. Now, the next violation that we see that's in the top 9 is not having training for employees. A simple thing, sometimes we have training, but maybe it's not really formalized. Maybe there's really no specific training day. Training is done catch as catch can, but it needs to be formalized. It needs to be once a year. It needs to be documented. Again, I want to keep all of you out of trouble. So some things that you want to remember: bloodborne pathogens, hazards. Again, at the time of initial assignment, at least annually when changes occur in the workplace. So what I would do is set your calendar and just make sure that you have annual OSHA and infection control training every year. A question I have for you. How many of you do OSHA annual training as part of your onboarding process, say for new employees, where right on day one, before they start, they're receiving OSHA infection control training? Looks like that's good. It looks like about 70% of you are doing that. About 70%. Now, a couple of questions. We're going to do a Q&A at the end, but I'm going to get a couple of questions along the way. Elizabeth asked, could the sink with a faucet that has 360 degrees of rotation feature be used as an eyewash station? Actually, Elizabeth, it can. You've got to have, by law, a binocular. That's the word binocular, so it has to hit both eyes. It has to deliver basically half a gallon of water a minute for at least 15 minutes, and it has to be tepid, which means between 60 and 100 degrees. So it's got to be specifically designed for an eyewash. I've seen a number of people over the years get cited, get fined for having something that kind of, I'll call it a homemade eyewash from a hose or a particular kind of sink, and that just won't work. Jamie asked, I have one that looks like the picture. I heard it needs to be hands-free. Absolutely not. Does not need to be hands-free. If you have one like in the picture where you pull the button, it pops off the caps, no problem. Someone asked here, when did TB testing become required? You know, I will tell you that the CDC has, I'm sorry, I think that the CDC talked about it a number of years ago, OSHA a number of years ago in the bloodborne pathogen standard. I'm going to say probably about 10 years, pretty close. But it's just something that not a lot of people are real aware of. But it's clearly something addressed by CDC, addressed by OSHA, and something that needs to be done as part of the onboarding process. And when you think about it, that's to keep our patients safe, which is on the CDC end. It's to keep our fellow employees safe on the OSHA end. Because remember, OSHA is all about safety for employees. OSHA doesn't really care about our patients. CDC is focused more on our patients. The next violation, failure to provide post-exposure treatment and counseling to exposed employees. I've seen this mistake happen time and time again, year after year. It's clearly in the top 9. And it's something that you want to have this ready to go, if you will. Everybody needs to know, what do I do if I get a needle stick, a scalpel blade cut, a splash of blood into my eyes? So let's talk just a little bit about it. First of all, post-exposure evaluation and follow-up, it needs to be provided to anybody who's exposed. It needs to be provided cost-free to the employee. So again, the time to do this, the time to have it set up, is before an accident happens. And again, that's where the occupational medicine clinic comes in. So let's just say you have that needle stick in your office. So notify the supervisor, and who's probably in this case the OSHA compliance person, but notify your supervisor and the OSHA compliance person. Wash it with soap and water. If it was somehow splashed in your nose or mouth, maybe you didn't have a mask on, flush that area with water. If the eyes have been splashed, irrigate them with water using the eye wash. It's a much better way to irrigate the eyes than just, cupping your hands and going to the sink. There should be incident reports forms ready to go. So what it's going to do is it's going to, first of all, let me state this. One of the mistakes I see is not having these ready. So have your incident report forms ready to go. there's basically going to be a form for the patient who you were exposed to, a form for the employee, a form that you're going to send to the occupational medicine clinic where they're going to do testing. And it's going to go over things like date and time of exposure. How did it happen? Where did it happen? What kind of body fluid? What kind of route of entry? And of course, information about who was exposed and who you were exposed to. So again, have these forms stapled together, ready to go. In fact, what I always like to do is have the forms ready to go, copies, several copies of them made right in the front of the OSHA manual, with even a map and directions and a phone number to the occupational medicine clinic. And employees really appreciate this because they're scared, they're concerned, and always much less so when they see you're prepared. So I'd like to know how many of you have already identified, and employees know where to go in the event of an occupational injury like this, a needle stick in your office. Forms ready to go, people know where to go. And it looks like about 65% of you have already done that. That's good. That's good. So let's see if we can't get it up to 100. Let me end this poll. Now, the next few slides I'm going to share with you are, this is an area, a mistake I see in the top 9 that I see in almost every inspection. Either lack of an exposure control plan or an improper exposure control plan. So some of the things that are going to be in the exposure control plan would be, of course, this evaluation and follow-up if somebody has a needle stick. So of course, we're going to identify and test the patient, the employee for hepatitis B, hepatitis C, and HIV, usually using what they call a rapid hepatitis B, C, and HIV test. Remember that post-exposure prophylaxis, maybe they need an immune globulin injection. Counseling, maybe over a few months if there could be a suspected disease involved. Evaluation of any reported illnesses that they get along the way. Again, you're out of the loop here. You send them to somebody who specializes in this. You simply need to make sure that they go. The source individual, whoever the patient you were exposed to, those test results will be made available to the employee. That really makes them feel a bit more at ease if they find out the hepatitis B, C, and HIV tests are negative. Now, after the employee has received their follow-up, the employer, you're going to receive basically a letter within 15 days, a written opinion, basically stating the employee knows the results, they've been informed of medical conditions that require further treatment, they're being followed up, they're in good hands. That's basically what should happen. And as I mentioned, not having a written exposure control plan is something that I see that's a problem often. Let me just minimize this. So an exposure control plan, again, this is something that is in your manual. It's required. It's a written document. A lot of times people think, well, I have an OSHA manual, and really what they have is a collection of SDS sheets, a few infection control protocols. But you need to have this written exposure control plan. Employees need to know where it is. And it's all about trying to minimize injury. So some of the things that need to be in the plan. What hazards do you have in your workplace? What tasks do you do that could expose employees? Which employees have exposure? Also, what about PPE? What PPE are you using? Where do they get it? How do they use it? Okay, these things all need to be in your exposure control plan. Let's see here. Here's someone, I want to get to some of these questions while they're close to the slide that prompted them. Someone asked here, what if the source person declines testing? That's a good question, Meg. It can happen. In other words, you can go to the patient, like Mrs. Smith, our dental assistant was just exposed, possibly to your blood through a needle stick, an accidental needle stick. we'd like you to go to this testing center, have a blood draw. We'd like you to fill out this form. They can decline. Most people will go. Most people will. You might have someone who says, for example, hey, I just had a blood draw 2 weeks ago or a month ago. I don't want to go again, but I'll get you those results. That might be acceptable, but you can't force them to go. But they need to either accept or decline, again, on this paperwork that you'll have ready to go. Forms ready to go for the patient, forms ready to go for the employee. Who does the follow-up, Elizabeth asked, of exposure incidents? Should it be an administrator? Well, actually, the answer to that is this. Once you give them those forms, send them to the occupational medicine clinic, that employee is now in their hands, okay? So you don't need to follow that up. They follow it up. They'll send you information, letting you know the employee's in good hands. But you in your office would not need to follow up on that. It's literally out of your hands. When it comes to things that need to be in the plan, it needs to discuss some of the basic things you might imagine, like standard precautions, which is, of course, treating everybody the same, treating everybody as if they had a disease. What engineering and work practice controls do you use? What housekeeping procedures do you use? How do people get the hepatitis B vaccine in your office when they're a new employee? What do they do for post-exposure? What kind of record keeping is done? These are the sort of things that need to be in the exposure control plan. And I'll tell you that it's a big part of your OSHA manual. The exposure control plan is a really big part of your OSHA manual. In there, it talks about things like, what barrier products do you use? Maybe you use air, water, syringe covers. Maybe you simply disinfect the air, water, syringe. Maybe you use barrier films. If so, where do you use it? I mean, you can't have one employee, one assistant, and one operatory putting them over some things, a totally different set of rules than the next operatory. So it needs to be these housekeeping procedures for consistency. Do you use reusable, autoclavable three-way syringe tips, or do you use disposable products like this? All of these things need to be in your exposure control plan. And once you have it, you have it. Things don't change a lot from year to year. As we go through this, I'm just curious, how many of you do have an up-to-date written exposure control plan ready to go in your OSHA manual? Again, we're not talking about your infection control guidelines. We're talking about exposure control for employees. Looks like about 60% of you. Okay. Yeah, about 60%. Now, one of the things that I mentioned, again, identifying which workers could be exposed, which is pretty much in the dental office, everybody, because even the front desk people, we're not like, again, LA General Hospital, where we have the 14th floor is all administrative. I mean, our front desk is usually pretty close to our operatories, to our labs, and those folks sometimes do double duty. You're going to want to review any procedures you do with potential exposure, and of course, review any new procedures that might cause exposure. Maybe you start to do implants or a procedure you didn't do. Remember, standard precautions is one of the most important things in your exposure control plan, so that everybody understands every patient is treated the same. Doesn't matter if they're a known drug abuser, HIV positive, or a friend who's in the office. Same disinfection, sterilization, cleaning, everything's the same. This all needs to be in your exposure control plan. Also, people sometimes forget to put things like the engineering controls they use. In other words, engineering controls are mechanical devices that make the office safer. And people need to evaluate these on a yearly basis. Employees need to know how to use them. If you have a needle recapper and people don't know how to use it, it doesn't do any good. You need to actually document in your plan that you test these new devices and that you as a group do a once a year safety meeting and talk about what technologies could we embrace that might make this office safer. Again, once a year, this needs to be reviewed. Another common mistake that I find in infection control and compliance. Posting a written housekeeping schedule I mentioned, so important, because if it's not listed, people are doing rooms different, labs different, depending on who's doing it, everything's different. Sometimes even different products are used. I remember today, somebody had called Compliance Training Partners. One of the techs was telling me, saying that, we've got assistants in our office who are using different products. In one room, it's one disinfecting product. One room, it's another. Our housekeeping schedule tends to standardize that. This is what a good housekeeping schedule would look like. In other words, it's going to tell you what things you do before the patient, after the patient, maybe some things you do daily, weekly, monthly. Who does it? What product do you use? Is it disinfected or is it barrier covered? So we're all trying to get on the same page with this. That's what it's really all about. One other mistake I see is mishandling of regulated waste. Just remember that to know what regulated waste is, you need to know what unregulated waste is. Non-regulated waste, that's just regular trash. These are things that just throw out in a black bag and in the dumpster. Pretty much most of the things from your operatory or front desk. Where regulated waste, that has specific requirements. You can't put it in regular trash. Things like sharps, because sharps need to be in a sharps container. Now, it says here sharps containers must be, and I list all these things. Trust me, if you're buying your sharps containers from Henry Schein, they're approved sharps containers. They're closable, puncture resistant, leak proof, labeled. The only thing I can mention here, don't overfill them. A common mistake that I see is overfilling these things, and now somebody is trying to push a needle down into there and gets a needle stick. I mean, that's the whole reason we have sharps containers, so we don't get needle sticks. So when they get about 7/8 full, seal them up, put a new one in there. And remember to have a sharps container in each room. A mistake that I see is carrying sharps to the back, carrying it back to the laboratory area. Instead, what you want to do is get rid of them where the sharps are generated. So a small quart or half-gallon one in each room. Another thing that needs to be in that exposure control plan is the personal protective equipment you use. Also, what type you use, how do you get it, how do you clean it, how do you dispose of it. And a mistake that I see again and again, taking protective equipment home to launder. In other words, if you're wearing scrubs or a lab coat, that is considered street clothes as soon as you wear it out of there. If you're wearing protective clothing, you need to leave it at the office. For example, I think an ideal way is to wear long sleeve scrubs at the office. In other words, you wear regular clothes to the office, you get to the office, you change. Before you go home, you'll leave your scrubs, long sleeve scrubs, at the office to be laundered or picked up by a laundering service. You say, well, can't quite do that. Okay, the next good option is you can wear your street clothes back and forth to your house. That's okay. Maybe short sleeve scrubs. You wear them back and forth. But what you've got to do when you get to the office is you've got to put on a long sleeve lab coat over that. Long sleeve, high neck, knee length, and leave it at the office for laundering. Something's got to be left at the office for laundering. It can't be taken home. A common mistake that I see, and I see people get into trouble for this. Someone asked here, and they make a good statement, the new COVID guidelines make this plan more complicated. Should we include this as an engineering control, the daily screening for employees, temperature intake? Not really an engineering control, because really engineering controls, I guess, refer to mechanical devices. What actually a screening is, and we're going to have, I think, a slide on it in a minute, is what's called a work practice control. In other words, a behavior, a protocol. Someone asked here on the regulated waste area, get this question a lot. We probably receive 150 to 200 calls on an average day at Compliance Training Partners. And we probably get this call at least a couple times a day. Can used and empty carpules be tossed in regular waste or trash? Here's what you want to do with carpules. My personal preference is to always make sure that the carpule is empty, because if you have a carpule with drugs still in it, now you're mixing categories of waste. You've got the glass, which I consider a potential sharps, with drug waste. So make sure your carpules are empty. That being said, empty carpules can either go in your sharps container, because they can be considered as sharps, or they can go in regular trash, but they need to be empty. And I will tell you, my preference is to always put them in the sharps container, because, you know, if somebody's dumpster diving and they cut themselves and blame some disease on you, I just don't like carpules in regular trash, even though technically you can do it. I always say put them in your sharps container, but make sure they're empty. Again, when it comes to PPE, make sure that you're using quality products. I'd really stay away from some of the questionable sort of online products. For example, what I like about this box of gloves, this is a quality, mask, I should say, this quality box of masks, is it says right on the end, on the left side, you'll see it says ASTM level 3. So you know it's providing the proper protection. You know it's actually a surgical mask, something that has passed ASTM standards, which is what we all need to be doing, not buying products that aren't approved products. When it comes to gloves, the same things, quality gloves that fit properly, of course, powder-free, because powder-free or powdered gloves are no longer allowed. Make sure you have a well-fitting glove. We're all going to be doing this for many years. If the gloves don't fit right and you're saving a few pennies and it causes tonus of your muscles all the time and you end up with hand problems, it's not worth the little bit you save. Now, the next violations are a set of violations I want to go over, which of course are really appropriate for what's going on today, are the COVID-related violations. And I'm seeing those pretty regularly. And here's what I see. Not conducting fit testing of respirators. In other words, if you're wearing a respirator, you need to conduct fit testing. And it's not hard. It can be, there's a spot on our website at compliancetrainingpartners.com where you'll actually see how to conduct fit testing, how to conduct it in your office. Not having a written respiratory protection plan. Again, if you're going to use an N95 respirator or a KN95 or KF94, whatever you might be using, and by the way, I highly suggest you use an N95 if you're going to use a respirator. You've got to have a written respiratory protection plan. Again, it's a very easy thing, but that document has to be made available. It's a top mistake that I see. And I will tell you that, let me just close this again. My poll just suddenly got big. There we go. My poll questions here. Not having a medical evaluation for employees who wear respirators. Okay. If you're going to ask an employee to wear a respirator, they've got to be fit tested. There has to be a written respiratory protection plan, and there has to be a written medical evaluation. Now, you can actually go to our website, again, compliancetrainingpartners.com, and you'll see the link to an online medical evaluation. So these are the big COVID-related mistakes that I see right now. So let's go on here. So with that being said, let's go over some COVID-specific things right now. Now, OSHA is all about keeping employees safe. That's still what they do. Keep in mind that their emergency temporary standard no longer applies to most dental offices if you're screening patients, if you're screening everybody who enters that facility, okay? The only exception that I see would be if you are an office that provides treatment to known or suspected COVID-19 patients, but that's probably not your practice. That's probably a hospital-based practice where they have a negative air pressure room that has HEPA filtration of all the air, UV disinfection of the air. That's not the typical dental office, okay? So we can be exempt from the emergency temporary standard if we screen everybody who comes in. And that even means if the Schein repair person is going to come in, they need to be screened as well. Now, following OSHA regulations, following CDC guidelines, it's always been important, but there's a couple things that you want to make sure you have, besides what I've already said tonight, the requirements, for example, for N95 respirators. Make sure you have a COVID-19 hazard assessment and a written COVID-19 safety plan. You can download these for free at compliancetrainingpartners.com. Just download it, fill it out, and have it available. It's a common mistake I'm seeing. If someone's inspected, they're going to ask for it. Remember, the existing regulations have done a really good job of protecting the dental team, but continue to do what we're doing. We have an extremely exemplary record for having no COVID clusters coming out of dental offices and an extremely low rate of COVID among dental employees, definitely far lower than the general public. So people ask us all the time, what should I wear? What sort of PPE should I wear? And here's what I like. If you screen everybody who comes into the office, now what you can do is make that decision based on whether your community is in low, moderate, substantial, or high levels of transmission. Because there's a big difference in the PPE that you wear if you're in substantial to high or if you're in low to moderate. So go to the CDC COVID data tracker. You can also, of course, utilize state and public health department data to see where your levels or your community's level of transmission is. And at this point, now you can start to determine what PPE should be used. So let me show you what I mean. And again, these are mistakes that I want to eliminate for you. When you're performing an aerosol generating procedure on patients who aren't suspected to have COVID, in other words, you've screened them, wear recommended PPE, including an N95 or equivalent, if you are in substantial or high levels of transmission. Now, if you're in low to moderate, that's a whole different thing. Now you don't have to wear an N95. Now, remember the N95 masks, these are considered respirators. So remember, you've got to have what I said in that previous slide, the respiratory protection plan, the fit testing, the medical evaluation. Again, you can find out about all of that on our website. And remember, what is considered aerosol generating in dentistry? Well, ultrasonic scalers, running the high speed, using the air water syringe, using an air polisher in hygiene, or using air abrasion. Those are all aerosol generating procedures. Those all would need N95s if you're in substantial or high levels of transmission. And if you're in substantial or high levels of transmission, the recommendation would be face shields or goggles as well. But again, you can use professional judgment, but you've got to have some justification for what you're doing by looking at that COVID data tracker. Remember that a face mask or cloth face covering needs to be worn at all times in the dental office, at all times, unless you're eating or drinking. Okay, it's not like a restaurant or other businesses where you can go in and it's optional. This means business office staff needs to be wearing it as well. You can wear cloth face coverings in the office at all times, except when you're providing patient care. The second you go to patient care, now you have to go to a surgical face mask or a respirator, depending on what procedure you're doing. But cloth face coverings can't be used if you're treating patients, and they need to be laundered daily as well. So we've always needed training on PPE, but I think it's especially important now during COVID, so that people know when to use it. Which PPE should I use? How do I put it on? How do I take it off properly? How do I disinfect it? Also, what are the limitations? In other words, level 1 surgical mask or level 2? That's pretty good. But is it going to protect me from COVID in an aerosol generating procedure? Probably not. Or a face mask. Face masks are great, but there's limitations. It's not designed to be used for patient treatment. Now, remember that training records for OSHA, you need to have the dates of it, who did the training, who attended, and these records need to be kept for 3 years. This is a mistake that I see, again, when people don't have these records. And what's really a shame, sometimes they're good offices and they've done the right thing, but they don't have records. It's a lot like a patient chart, right? If it's not written down, it didn't happen. So some other areas I want to remind you of before we do Q&A, just remember some really important things that can keep you out of trouble are these OSHA subparts. Many times the mistake I see people make is just focusing on infection control. That's it. Ignoring things like means of egress or fire safety or electrical safety or non-ionizing radiation, radiation from a curing light or a laser. So these are things that we need to look at too, to keep you out of trouble. I want to mention a little bit about OSHA inspections. I'm going to tell you that, first of all, I find OSHA to be really fair, to be really reasonable. I've really only a few times in my 25 years of doing this run into inspectors that were unreasonable. Basically, the things I talked about tonight, I mean, there's no secret to what they're looking for. They're going to want to see a written hazard communication plan. They're going to want to see SDSs. They're going to want to see your written exposure control plan, your training records, all the things I talked about tonight. They're going to talk to employees and see, hey, do you know where your Eyewash is? Have you ever been trained? They're going to inspect your facility, make a few notes, respond in a couple of weeks. But I'll tell you that they're quite fair and reasonable, but do the things I'm talking about tonight. That's the mistake that I see. Probably the biggest mistake I see is not taking this stuff seriously until you've got a problem. And then it's really a problem. Now, sometimes people aren't as concerned about CDC guidelines because they say they're not law by OSHA. Just keep in mind, OSHA can enforce CDC guidelines. They do it under OSHA's general duty clause. So all the things we talk about in infection control, as far as I'm concerned, are requirements by law, because our state dental boards enforce them, public health departments enforce them. If we ever are unlucky enough to go to court, the public expects us to be following them, as do courts, as do judges and juries. So one of the things that I want to talk about here is an audit of your facility. One of the things that will be sent to you after this course will be an OSHA audit checklist and infection control audit checklist. And I'm going to really, really encourage you, print these out. If somehow you don't get one, simply contact compliance training partners. Just tell them you were on this course. You want the detailed infection control checklist and the detailed OSHA audit checklist. And now you can go through and see where are you in compliance, where are you not. Okay, some of the things we talked about tonight, protective clothing and personal protective equipment in general. All of these things, print these out, make copies, go over this once a year, okay? This should be a once a year thing. That's how to conduct an OSHA audit. Whoever's in charge of OSHA goes through with these checklists and carefully looks at these items. That way, you won't have any surprises should you ever be visited or ever be challenged by a patient. So again, to keep current, we always invite you to visit our website. We have the most current COVID information as well as information on training requirements, and identify yourself as having been part of this webinar, and certainly our technical people will be glad to help you. Now, with that, I'm going to take some questions, and then we will, yeah, I've got a few questions up here right now. I see I have some on the chat button and some on the Q&A. Prefer them on the Q&A button if you can. Says here, here we go. No, this isn't a silly question. Somebody said, they said, silly question, do we need to include office cleaning service people to review the exposure control plan? I'm really glad you mentioned that. And of course, I didn't really have time to go over every little bit of detail. That's why Henry Schein has me do quarterly, we do annual OSHA training webinars that are 3 hours in length to fulfill the annual OSHA training requirements. And one of the things we talk about is cleaning people. Now, technically, they're not your employees, right? You probably have an outside cleaning service. But I will tell you that you really need to take your cleaning people and at least go over the basics with them. You need to walk them around, show them where they can get into trouble, show them where regulated waste goes. Tell them a little bit about bloodborne disease and why they shouldn't reach into the sharpest container, why they shouldn't reach into the trash containers in your operatories. So is it really required? No, because they're not your employee. Is it the right thing to do? It is. And could you look bad, even though they're not your employee, if they contracted a disease, cleaning your office, and they said, we've never been trained, they never told us? Yes, you could look really bad. Absolutely, even if it's a 15-minute orientation, orient your cleaning people to protect them. Someone asked a question here regarding voluntary use of respirators for the staff. If they decline to wear them in aerosol procedures, do we need to document delegations? Well, what I would say, Elizabeth, is if you're telling people that they need to wear these and they won't, there needs to be some type of disciplinary action. I always suggest that in your office manual, your employee policy manual, you state failure to follow OSHA, HIPAA, and infection control guidelines as caught may be grounds for dismissal. I mean, they've got to know that you take this seriously. If you're getting respirators for them, you're telling them we're doing an aerosol generating procedure and they won't wear it. If you're not enforcing it and they get a disease, guess who'll get in trouble? You will. Is a level 3 mask okay to wear in surgical procedures? Well, actually, Terry, it is. A level 2 or level 3 mask is really good in surgical procedures in normal times. And they'd be good right now if you were in an area of low to moderate transmission. If your community is in low to moderate transmission, absolutely. If you're doing a surgical procedure that generates aerosols, probably using the high speed or cutting bone, sectioning a tooth, and you're in a moderate to substantial, no, that wouldn't be okay. Then you need to go to a respirator. Here's a good question. If staff wear their own respirators, and for example, an administrator, do we need to administer a fit test evaluation? Yes, you do. Even though it may not seem right, yes, if a staff member says, look, I know I don't need to wear an N95, I want to wear one. If they're wearing a respirator in your office, there needs to be a fit test, a medical evaluation, a respiratory protection plan. Again, go to our website, you can download those things. What are the penalties for the violations? Well, they can be all over the board. It depends if that violation is tied with other violations. For example, there's typically when they come in, if say it's a COVID violation, but also there's no record of training, there's no Eyewash, there's no OSHA compliance manual, they can get pretty expensive. To me, what's even worse is the downtime for the office. You can't believe if you have an inspection go bad, now they got their teeth into your leg. They're in there again. It takes time. And yourself, what does it cost when your office is shut down? It costs thousands of dollars. It also gets the employees really riled up. And that can open up other things. For example, lawsuits that they've been harmed in the office. This is public domain information. Patients can read about it. So penalties, it could be $5,000 to $25,000, $30,000, $40,000. Technically, it could be a lot more. I don't usually see them fine you that much, but all of the things together, it's really expensive. far more than that. Do you need to wear a face shield and safety glasses, or can you just wear a face shield? You can wear either a face shield or safety glasses. You don't have to wear both together. But again, keep in mind that if you're doing an aerosol generating procedure and you're in a community that has substantial to high transmission, you're going to want to switch to a face shield or goggles rather than safety glasses. Diane asks, she says, I assume all volunteers of dental volunteer events also need to follow infection control and OSHA guidelines, even though OSHA only affects employees. Absolutely, they do. And you said, I have a dental van volunteer refusing to do so. You know, be really careful there, Diane, because the problem is, I know the law reads that OSHA is for, quote, employees. But if you have a volunteer and they get hurt and they then claim that they were injured because they didn't receive training, they weren't protected, they're going to, it's possible that the legal system could construe it as a employer-employee relationship because you're directing them what to do. So, you know, if you've got volunteers who won't follow the rules, you're putting that whole organization at risk. How should uniform shoes be handled in educational programs? Again, in an educational program, really the same rules would apply. If whatever clothing they're wearing to work, when they go into the clinic, they need to wear some protective clothing. That could be, your program guidelines could be, we want you to change into scrub pants, long sleeve scrub top, leave all of those, including the tennis shoes that they're wearing at the clinic, at the office, at the school. Myself, I will tell you, that's what I always did, even before these rules came out. Bought a pair of cheap tennis shoes, bought long sleeve scrubs and scrub pants. I left everything in the office. I didn't want to bring any of it home. But if you ask me, Tammy, what can you get away with? You could get away with just having everybody don a long sleeve, high neck, knee length gown and leave it at the office. That being said, I'd like to see you do better. Have them leave the pants and the shoes there as well. Does OSHA notify you before they come for an inspection or audit? How often do they perform inspections for an office? You know, sometimes they'll notify you with a written notice. Sometimes they'll show up on your doorstep. I've seen both. Quite often, it comes by mail. The first step, they want to see where you're at before they come in. Sometimes they see it just as a disgruntled employee who wants to make your life miserable. Well, you can make that go away pretty quick. We've helped a lot of our clients make those go away if they have done the things we talked about in this course. They can produce data sheets, training records, copies of their exposure control plan, copies of their hazard communication plan. So I'm really confident that you can make them go away if you've done the things we talked about here, whether they show up live or come through the mail. Does the fit test need to be done yearly? Yes, it does need to be done yearly, and the respiratory protection plan revised. Really shouldn't be any changes in the respiratory protection plan once you have it, but fit testing does need to be done once a year. I will say, though, that because of the requirement for annual OSHA training, certainly you need to review the need and how to put on a respirator once a year. Here's another really good question. These are really good questions tonight. Work interviews, temporaries. How can we enforce OSHA regulations for those who are technically not employees? You know, you're right, Elizabeth. That is a real area of concern. We've had to really change our policy for work interviews. I mean, if you want to have somebody come in and talk to them and you know, see how their dental knowledge, if you will, you can do that. But you've got to understand that if you're going to put them in, say it's an assistant, you want them to do a working interview. Well, if they're going to sit down and handle sharps and work on a patient, they've got to have some kind of training. So, you know, these temporary interviews are really concerning. There can be a lot of liability associated with that. I don't really recommend them for that reason. Do you still have to change lab coats between each patient? I will tell you that if you were doing an aerosol generating procedure in an area with substantial to high transmission, absolutely yes. If you're in an area with low to moderate, the answer would be no. Well, with that, I think I have got most of the questions answered. I really appreciate everybody's time. We went a little bit over here, but I was glad to answer the questions. Thanks to Henry Schein for sponsoring this. And thank you to all of you for your interest in safety and infection control. And I hope to see you on a future webinar. Thank you again.